So for our presentation, we had gotten chapter 16, which is elastography, presented by Mitchell, Madison, Nicole, and myself, Charlene. So before elastography, we were able to get a feel for tissue stiffness through palpation. Palpation is a method of applying pressure through our fingers to detect masses and nodules within the body. We are physically able to feel for stiffer than normal tissue that may indicate cancerous tumors, inflamed or infected tissue, or also for areas that may be softer than normal. In addition to palpation, we have used transducers to get a rough estimate of tissue stiffness through echopalpation. Echopalpation is the method of applying pressure with the transducer to our patient and looking at the response of the tissues. When we apply pressure with the transducers, stiffer tissues move relative to the pressure applied without really compressing, whereas softer tissues will compress like a sponge. So moving on to the history of elastography, through palpation, we've provided additional techniques around the early 1980s to monitor tissue motion through M-mode. Remember that M-mode displays depth over time, but the motion changes are observed by the changes that we see on the screen. In 1987, we implemented sonoelasticity, which is imaging tissue stiffness, with the addition of Doppler. We'll come back to that later on. Later, in 1991, we applied those same palpation techniques deeper into the body, leading into elastography. So elastography, which is the topic of our presentation, is simply defined as true tissue elasticity imaging that can be categorized into two methods, which are either quasi-static or dynamic. Quasi-static, or just static elastography, was the method that was first used when elastography was developed in 1991 and is based on the imaging of tissue before and after compression, which is the first method that we talk about. And dynamic elastography is imaging of tissues as a vibratory wave travels through it, which will be later discussed by Mitch. The method of elastography consists of taking two images, one before any changes are made, and the second is taken after applying compression to the tissue. The raw RF signal in the two images are compared by a processing window in a cross-correlation function. In this function, the processing window runs through the pre-compressed signal information and looks for a match in the post-compression signal, which can be seen in the image. And when it finds a match, the system measures the distance that the tissue has displaced before and after compression at a certain depth. This measurement is then compared to an overall depth of the RF signal. So elasticity can be measured by the displacement of the front and back end of a structure when applying compression. For a squishier structure, like the soft mass, the displacement of the front end will move more than the back end, and for a stiffer structure, the displacement of the front end and the back end are approximately the same, which is shown in the diagram.
So the other category of elastography is dynamic elastography. The first methods of dynamic elastography use color Doppler to detect responses in tissue caused by some sort of external vibration device. The very first method of dynamic elastography used was Summative. This was a measurement of vibrations felt on a patient's chest during vocalization, which was first used for detecting breast lesions. Color Doppler would image movement of the tissue while the patient would hum. Unfortunately, Summative had a number of accuracy issues. Its intuitive nature, the sensitivity of Doppler settings, and every patient hums at different pitches and volumes. Sonoelasticity was developed based on the Summative accuracy issues. Color Doppler was again used to measure tissue movement, but a piston-mounted transducer was used as the external vibration device. Tissue movement detection was more precise since the external device would produce identical vibrations in each study, which produced a more accurate measured response. Sonoelasticity and Summative were based off the fact that stiffer tissue would vibrate less than softer tissue when an external vibration was applied. An approach of dynamic elastography is the use of shear waves. Newer dynamic methods can track the velocity of vibrations as the vibratory waves travel through the tissue. An external vibration device, like a piston-mounted transducer, creates compressions on the tissue and sends waves traveling through the tissue. Because of these waves, also known as push pulses, shear waves are produced. Shear waves propagate perpendicularly and at much slower rates than the push pulses. Since the shear wave's speed is slower, the ultrasound system can track the very fine displacement of the tissue caused by shear waves. The speed of the shear wave is determined by the stiffness of the tissue. They will travel much faster through stiffer materials and much slower in soft tissue. The relationship between stiffness and speed of the shear wave is represented by the shear modulus equation, G equals Vp, where G is the shear modulus, V is the shear wave velocity, and P is the density. Important points to take from this are that dynamic elastography methods are becoming more and more desired because they are capable of generating quantitative estimates of tissue stiffness, and that a time-varying force is applied to the tissue compared to a constant applied force in static elastography.
Okay, so moving on to elastogram presentation. So for both static elastography and dynamic elastography, we can generate elastograms to be viewed on an ultrasound. As mentioned before by Charlene, static elastography measures relative strain. Using static elastography, we can determine the strain by measuring the displacement of an object's front end and back end. That was discussed previously. Computers then quantify the strain values for each depth along a radio frequency line. The quantifiable information or number values are then converted to a color or grayscale. This is similar to how we convert A mode information or the amplitude values to B mode, displaying as shades of gray. A general rule to follow is low strain values or stiffer materials are displayed as dark regions, and high strain values or softer tissues are displayed as brighter regions. There are many areas of hard tissues throughout mass, but most of them are insignificant. It may be hard to know if a lesion truly exists. So, elastograms are viewed in conjunction always with a sonogram. So, to be able to identify disease accurately, we can either display the sonogram and elastogram side by side or through an overlay approach as shown in the picture. The benefits of an overlay is that it provides the easiest comparison between an elastogram and a sonogram to identify unwanted structures. However, it may limit the dynamic range. This may make it difficult to analyze internal characteristics of a lesion with overlay, so it's kind of a balancing act. Recall that static elastograms compare pre-compression to post-compression images. One way to do this is to physically compress the transducer into the patient's tissue. This approach is used specifically for breast elastography, and the other way is to keep the transducer still, and the compression required to develop an elastogram is generated by the movement of patients' breathing. So we take a picture of the before generated images, and as they inhale and exhale, we take another picture afterwards. A series of elastograms are generated and saved in CineLoop to review later. This helps us with bad quality elastograms to ensure that our best images are not lost. Moving on to quality, we can talk about good quality and bad quality elastograms. So good quality elastograms are mostly a homogeneous display of gray. Bright bands may exist before and after stiff regions still, but they're not reflective of real changes in tissue stiffness. We have to understand that the concentration of strain at the boundary is just a higher value, so it may appear brighter. Bad quality elastograms, however, appear mottled, speckled, or blotchy, just like the picture shows. It's difficult to properly diagnose a patient with an elastogram that is indiscernible. Bad quality elastograms can result from too much compression, patient movements, or even too little compression. Too much compression results in the raw line being too difficult to quantify. Think of squishing something as hard as you can and all the tissue morphs into each other. It's difficult for the computer to quantify information that's all jumbled together. Patient movements make calculations inaccurate, and too little compression, just remember that low strain values appear dark. So without enough compression, differences in tissues will be super tiny, and recorded strain values are hardly useful anymore. So the screen may just appear super dark or black. Quality elastograms are variable and sensitive. Compression amounts, variation in tissue stiffness, unwanted movement, and inadequate computer systems can make it difficult to achieve good quality elastograms. And discerning between these elastograms may even be more difficult than generating a good quality elastogram itself. And it's hard to know if the image is good quality or bad quality. This is why we have quality indicators. Ultrasound manufacturers provide us with quality indicators. They help us know if it's a good image or a bad image. Based on correlation mentioned briefly by Charlene again, we can quantify the quality of the coefficients if they are less accurate. Hopefully, our segments are based on a coefficient of 1 because multiplying 1 or a number by 1 is equal to that same number. But elastograms with a low coefficient may produce bad quality elastograms or inaccurate representations of tissue stiffness. Quality indicators are displayed on the screen as a number or percent to distinguish images of good quality with images that are of low quality. If the images are just really bad, the system may completely disregard our request to generate the elastogram, so we're unable to diagnose a patient using this approach. Misdiagnosing a patient with a bad quality elastogram has worse consequences than just not producing an ultrasound elastogram altogether.
Okay, so today's static elastography is the most common method of tissue stiffness imaging. As mentioned before by Maddie, the images show the relative stiffness of the tissue where a brighter pixel represents a softer area with higher strain than a darker pixel within the same image. Pixel brightness is based on the relative stiffness as opposed to absolute stiffness. This can vary from image to image, even if they have the same stiffness. Static elastograms are great for detecting focal abnormalities, but when there is not as harsh of a contrast between the disease and the surrounding tissue, they are not as sensitive. So abnormalities like diffuse breast cancer and chronic hepatitis, which increase stiffness over a large region, are poorly visualized using this method. If we calibrate the strain image to take into account different amounts of compression, like patient respiration, transducer compression, or any other motion, we can make static elastography more sensitive for the detection of diffuse disease. The three methods to do this are 1. Measuring the pressure applied by the ultrasound transducer, 2. Computation of the strain relative to a known structure, and 3. Using calibrated standoff pads. With this method, the user chooses a region of interest in an organ or lesion that they suspect to contain pathology. Then they select another region of tissue not involved by pathology to compare it with. Skeletal muscles or fatty tissues are some popular choices for this. The strain ratio between the two is then calculated and either displayed as a numerical value or a color overlay over the image. Strain ratio is equal to the lesion strain over the reference strain. This is the best method of quantification because it doesn't require any additional hardware. You only need software modifications. The last method is using calibrated standoff pads. This is where we use a standoff pad of known stiffness and insert it between the transducer and the skin. When elastography is performed, the stiffness of the structure in the image can be compared with the stiffness of the standoff pad by calculating the strain ratio between the two. This method has not become as popular due to the fact that the third parties have to manufacture standoff pads that contain internal scattering while controlling the stiffness of the material as well as the stiffness of the pad may differ depending on how it is fixed to the patient or transducer. The last reason this method hasn't had a great deal of success is the need for a wide range of pad stiffness. If the stiffness isn't similar to the tissue being examined, it will result poorly and will give poor accuracy when measuring pad displacement and inaccurate stiffness estimates for underlying tissue.
Dynamic elastography is presented using dynamic elastograms, acoustic radiation force impulse imaging, ARFI, magnetic resonance elastography, MRE, poroelastography, and axial shear strain elastogram, ASSE, are some of the methods used today. The first one I will talk about is ARFI. ARFI uses a strong ultrasound pulse to generate an external push vibration. The strong pulse, which is a radiation, compresses the tissue enough that a measurable shear wave is produced. When the radiation force displaces the tissue of a focused spot, the transducer switches to an imaging mode and can then detect the displacement and relaxations of the tissue. Magnetic resonance elastography, MRE, uses a non-magnetic vibration device to introduce shear waves into the body non-invasively, which then can measure the stiffness of soft tissue. However, even though MRE can be integrated into most MRI systems, MRI is a very costly, time-consuming technique. The use of MRE can be limited due to the cost and the fact that ultrasound systems can have comparable capabilities and are more readily available.
Before moving on to a new method of dynamic elastograms, we can discuss the concept of Poisson's ratio. This ratio and quantitative assessment is based on the difference in lateral strain versus axial strain. So it's super easy to visualize if you think of stretching a rubber band. As we pull outwards, we are affecting lateral strain, and the axial strain will also be affected by decreasing. Moving on to poroelastography, which uses this concept. So poroelastography is the reflection of fluid movement. Porous material, including tissue, has fluid between cells, or interstitial fluid. Fluid may move away from a pressure site. So just like pushing on a sponge forces water away from the side of force, pushing on tissue may force fluid away from the transducer. Just as static elastograms are generated, multiple images are produced as pressure is applied to show displacement of fluid. Poisson's ratio is computed at each frame, so it is more quantitative because it's a dynamic elastography method versus a static elastography method. Understanding the change in Poisson's ratio can help us understand fluid rate changes in the tissue. We can monitor lymphedema effects and fluid draining with this technology. As you can see in the photo, normal tissue, the ratios are constant with little fluid flow. But fluid-rich materials, there's a decrease in lateral strain with a decrease in Poisson's ratio. We can see contrast between lymphedema effects and normal arm effects. The final method of dynamic elastograms that we discuss are axial shear strain elastograms, better known as ASSEs. This method is also generated by comparing axial strain versus lateral strain. When we apply a constant strain to the axial dimension, ASSE measures the resulting strain in the lateral dimension, or vice versa. As a constant force is applied to the lateral dimension, we measure the strain values that occur in the axial dimension. Around a lesion of different stiffnesses, either tissue softer or stiffer, high strain changes will occur at that boundary. This technique makes it easier to distinguish between diseases that may appear similar on a regular sonogram, as you can see in the photo. ASSE further analyzes the boundary between a disease and the patient's surrounding tissue. ASSE determines if the mass is mobile or immobile. Mobile masses essentially slip in the place in its tissue. This may indicate that the disease is benign. If the mass is immobile or is firmly attached to surrounding tissue, it may indicate that we have disease such as cancer or a tumor.
So to conclude, there are a number of different methods of elasticity imaging. Some of the older methods like Summative are not used today since technology has had such advancements. The other methods previously explained are constantly being improved. The most popular use for evaluating benign and malignant masses are in the breast. The image below is a large breast fibroadenoma study. Breast exams were also the earliest use of elasticity imaging. Elasticity imaging is also used for monitoring tumor ablation and used in chemotherapy. New elasticity imaging applications are used in dermatology, evaluating liver and kidney transplants, detecting prostate cancers, lymph nodes, thyroid nodules, liver stiffness and cirrhosis, and the list goes on. Elasticity imaging in the clinical world is used in a vast number of applications, and they are constantly being improved as technology advances.
Thanks, Carmen.